Hello, guys. Good evening. Dr. Ajit Singh here, National Director for Research, World Youth Heart Federation, India, and I'm working also as a senior drug scientist at Scope Medics. So today I'm going to present on the epidemiology of heart failure in South India, disease-specific prevalence, phenotypic classification, and risk factors from the Manipal Heart Failure Registry. So for that, I will share the slides with you. Yes. Yeah. So this is the topic of presentation today: epidemiology of heart failure in South India, disease-specific prevalence, phenotypic classification, and risk factors from the Manipal heart failure study, Manipal heart failure registry. This is my team. In that, Dr. Tom Devashia, HOD Cardiology, KMC Manipal, Dr. Yashwantrao Gargala, Professor of Pharmacology from St. James Medical Institute, Anguilla, Dr. Hasir Karim from Kerala, KIMS, Kerala, and these are the other colleagues who are participated in my study. So I'll come to the contents. We are going to talk about the background, why we have done the study, about the purpose of the study, material and the methods we have used, and what are the results and outcomes we got, and we will discuss them further. So authors or I do not declare any conflict of interest with this particular study. So magnitude of the problem and epidemiology of heart failure in India. If we see worldwide, heart failure is a progressive disease and it is emerging as a high epidemiological burden everywhere. Approximately 2 to 5 million patients of heart failure are existing in India, and it is responsible for approximately 1.8 million admissions annually in our India. And our Indian patients of heart failure are very much younger uh, against the US and Europe population. In India, it is just 53 years against 69 years of the Europe and USA. And the in-hospital mortality is very much high. As you can see here, it is 10 to 30% in India against 4 to 7% in US and Europe. So this data, the epidemiological data, what we read in literature is very limited from the low and middle income countries. And all the projections has come or estimated from the Western countries like European countries and American countries. So we are very much lacking of this epidemiological data of heart failure. We have assessed the heart failure epidemiological burden and disease specific estimates of prevalence in our South Indian adult population, more than 18 years of the population, at a tertiary care center hospital of Manipal Academy of Higher Education, within the associate hospitals and primary care centers. Also, we have done that. So this is the institutional level registry, institutional level heart failure registry, where we have included all the institutes, all the associate primary care centers to Manipal Academy of Higher Education for consecutive 3 years, 2016 to 2019, in various cardiac and non-cardiac conditions. So study site, as we have done this study at Department of Cardiology, Kasturba Medical College and Hospital Manipal. It was a prospective registry study from 2016 January to December 2018. It was cleared by Mahe Ethics Committee, and all the eligible patients were admitted from 1st January 2016 to 31st December 2018 were taken or were included into the study. We have included all the patients more than 18 years of the age, male and females both, patients with a documented diagnosis of acute heart failure or chronic heart failure with acute exacerbations, as it was decided by the physician according to their local practices and their clinical judgments based on the investigations, based on the biomarkers based on the history and examinations. We have excluded all the patients who were participating in any other clinical data with the investigational treatment, which can impact, which can have an impact on our study outcomes. And we also excluded the patients with the life expectancy less than 1 year because we are following them for a long term. Patients with severe psychiatric illness, where it can affect their lifestyle, their medication adherence, and can worsen the heart failure condition, we have excluded. So we have adopted the diagnostic criteria in multiple ways. As based on the duration of onset of symptoms, we have divided our patients into acute de novo heart failure and chronic heart failure for more than 3 months of the presence of the symptoms. And based on the ejection fraction, into three categories: heart failure with preserved ejection fraction, where ejection fraction was equal to or more than 50%; heart failure mid-range ejection fraction, where ejection fraction was set up to from 40 to 49%; and heart failure with reduced ejection fraction, where ejection fraction was set to less than 40%. We have also divided our patient or classified our patients based on the NYHA functional class into four classes. One, where there is no limitation for physical activity. Two, where slight limitations, symptoms at ordinary activities, comfortable at rest. Class 3, remarkable limitations, symptoms at routine activities, comfortable at rest. Class 4, where the patient was unable to do the routine activities, even symptoms were appearing at the rest. So these are the, now we will come to our results and discussion. Here we can see the year-wise distribution of the population. We have screened around 1,68,000 patients in the hospital. It's a huge number, 1,68,000. Out of that, eligible population was 1,38,827. Ineligible population means pediatric patients or the age less than 18 years and with the severe psychiatric illness or who were participating in other studies. So out of these total 138,827, we got 39,687 patients with the cardiac conditions, including heart failure at the cardiac conditions. Now, if we come to the heart failure population specifically, so out of this total population, we got 1,918 patients of heart failure during these 3 years of the study period. So here we can see it was 1.4% of the total population, 1.4% of the total eligible population. So we can say the prevalence of heart failure is 1.4%. Out of these 1,918, 58% were male and 42% were female. So the surprisingly, our mean age of the patients was somewhere very high, which is 65 years, and average duration of hospitalization of our patient in Manipal heart failure registry was 5.5 days. If we come to the age groups, majority of the patients were lying in like 40 to 60 years of the age. Even 54% were in the 61 to 80 years of age, and 41 to 60 years, 29%. And even in our study, we got 12% of the patient who were more than 80 years of the age. NYHA function class at admission, we did not have any NYHA class patients in category 1, but at discharge, we got around 45% in 2 and 22% in class 1. It is because of the treatment and best guidance and medication adherence and appropriate therapies. So if we look at the symptoms, most of the patient were appeared to the hospital with dyspnea, fatigue, and orthopnea. In signs, most of the patients were showing elevated jugular vein pressure, low urine output, pulmonary rales. When we have analyzed the etiology of heart failure, ischemic etiology was the highest with 39%, then non-ischemic cardiomyopathies with 24%, then hypertension with 17% of the proportion, and then when this valvular heart disease were very less, 5%, But unknown etiologies were 15%, where we have included infectious diseases, other infections, and rheumatoid heart disease, and the similar conditions, the minor conditions. So our population, when we have classified into three categories based on the ejection fraction, our 50%, 50.5% patients were in heart failure with reduced ejection fraction, where ejection fraction was less than 40%, and 30% patients were heart failure with mid-range, and 19.4 with the heart failure with preserved ejection fraction. If we look at the disease-specific prevalence, anemia showed the 4.3% of heart failure. I mean, we can say like in anemia, 4.3% patient can develop heart failure. In hypertension, 5.2%. In diabetes, 7.2%. In any renal insufficiencies, it is 3%. In thyroid dysfunction, it is 2.8%. So when we have analyzed the, sorry, I think we lost somewhere. Yeah. When we analyzed the factors associated with the probable diagnosis of heart failure, we got the age group 61 to 80 years of the AAs were more prone to get heart failure. Of course, we say it like heart failure is the is the disease of elderly. So it is proven and it is highly associated with this age group. Smoking was not associated. In other comorbidities, hypertension, anemia, VHD, and IHD were associated. Sorry, VHD was close to the significance, but it is not significantly associated statistically. If we compare our Manipal heart failure registry with other Indian, Asian, and global heart failure registry, we had a lot of surprising results, as we have recruited 42% of patients who were female against only 31% in THFR. Our mean age was 64.3 years. IHD was around 39%. As the etiology, non-ischemic cardiomyopathy was the highest in our study, which is 24.2%. Similarly, if we come to the comorbidities, anemia, which was not at all diagnosed in any other study, it was 43% in our heart failure patients. That means our heart failure patients are developing anemia as a major comorbidity. You can see these are the highlights of our study. In our study, we also seen that acute de novo heart failure was the highest. That means we have got 68.2% patients with the acute symptoms, with the acute exacerbation, or with the newly developed heart failure. So if we come to the conclusion, the cumulative heart failure prevalence was estimated 1.4% in a study population from our center. Prevalence of heart failure was more in men than women, that is 0.8% versus 0.6%. Heart failure was more prevalent in patients with hypertension in cardiovascular conditions and anemia in non-cardiovascular conditions. Major MHFR analyzed a large proportion of females and elderly, as we can of the patients had the age more than 75 years. MHFR refined the risk factors and etiologies of heart failure. IHD and non-ischemic cardiomyopathies were significant contributors to the heart failure development. These are the references we have used, and thank you very much for listening this presentation. I'll just stop. Yeah, I will end the meeting.